Looks good. Okay, great. All right, so sorry about the technical difficulties. My name is A Hysong. I'm one of the PGY3 orthopedic residents, and my talk today will be on intramedullary fixation of metacarpal fractures, a new technique or a relatively new technique in hand surgery. I have no disclosures relevant to this topic. So to start with this tibial shaft fracture, and I could ask most orthopedists in this room how they'd want to treat this, and a majority of them would say today in orthopedics that you treat this with an intramedullary nail or you'd nail it. Similarly, with this subtrochanteric femur fracture, same thing. You'd nail it, in this case, the cephalomedullary nail. And with this proximal, this comminuted interarticular tibial plateau fracture, well, kind of depends on who you ask, but that's kind of beside the point. So why has nailing become the gold standard in orthopedics for so many long bone fractures? Obviously, there's different types of fracture fixation. Well, one, it's biology preserving, reduced soft tissue stripping in order to place your fixation. Two, it's load sharing, allowing for earlier range of motion and return to weight bearing. It's been shown to have increased union rates, decreased infection rates, and decreased hardware failure rates. When we look briefly at osteology and bone healing, we see that this load sharing allows for micromotion at the fracture site, allowing for callus formation through secondary bone healing, which allows for a robust healing response compared to primary bone healing with intramembranous ossification. So knowing this, what now? You see this 22-year-old left-hand dominant healthy male who struck a wall when he was angry. He's a manual laborer, works with his hands daily, and he likes to paint as a hobby. He has this angulated, rotated second metacarpal shaft fracture. And how about this patient, a 30-year-old female involved in an MVC rollover? She's a contralateral pilon fracture, a contralateral humeral shaft fracture, and she's currently in the ICU because of her injury burden. And then finally, you have a 30-year-old right-hand dominant mechanic. He had an injury about 4 months ago, and he noticed that he's been having a lot of difficulty gripping and pain using his tools at work. X-ray show that he has this fifth metacarpal neck malunion. So to take a step back, let's look at the epidemiology of metacarpal fractures. They compose about 10% of all fractures, up to 40% of these, 41% of these, or these compose about 41% of hand injuries coming into the emergency department. And a majority occur in young males from a fall, a crush injury, or a direct blow. And oftentimes, I'll tell you, it was to a wall when they were angry. When we talk about the impact of these fractures, these two quotes kind of summarize it well. Richard Smith states that the versatility and power of the human hand are largely dependent on the smoothly balanced function of the intrinsic muscles of the fingers and the long flexors and extensors. Scott Cozen in a review article states that the longitudinal bones of the hand form a jointed system of levers between the forces of the flexor and extensor tendons. Fractures can disrupt this sophisticated mechanism, leading to impairment of hand function. So what are our goals of treatment when we're treating these fractures? It's all about balance, like any fracture that we treat in orthopedics. We want to restore skeletal stability while maintaining hand function. And additionally, early motion is critical because stiffness is a big problem in hand surgery, and it's something that we want to avoid. So briefly looking at the anatomy of the hand and the metacarpals are concave on the palmar surface. They create the longitudinal and transverse arches of the hand. In this image below, we can see that the index finger and the long finger CMC articulations are relatively rigid with the plate that's on there in that little depiction. And the fourth and fifth digits are relatively mobile, allowing for flexion, extension, and slight rotation, which become relevant soon. Additionally, the interossei, or in the intrinsic muscles of the hand, start volar to the axis, the central axis of the metacarpal, and they insert distal and dorsal distally on the fingers. This almost universally results in an apex dorsal deformity when patients have metacarpal shaft and neck fractures. So what are our options for fixation? Well, most commonly and successfully, these are treated non-operatively with casting and immobilization. But when we do operate, we have smooth K-wire fixation, plate and screw fixation, fixation with lag screws, rarely external fixation, and the point of this talk, we have intramedullary screw fixation. We'll focus on the more common fixation types throughout this talk. Surgical indications. So when do we operate if they are treated successfully, non-operatively so often? Well, open fractures are obviously an indication for irrigation, debridement, and fixation. Polytraumatized patients are a relative indication, allowing for early mobilization. Intra-articular fractures, multiple shaft fractures in the same hand. Rotational malalignment of a digit is typically an operative indication in any of the fingers. And significantly displaced or angulated fractures are also an indication. And as I mentioned before, the relative motion at the CMC joint directly correlates with the amount of angulation that is permitted. So the fourth and fifth digits, the long and the small, you can have much more angulation distally in the shaft because of the relative motion proximally. So when looking briefly at percutaneous pinning, what are the proposed benefits of this fracture fixation technique? You have minimal soft tissue dissection and you have relative stability. However, multiple studies over the years, starting in 1990, show that there's up to a 20% overall complication rate with this type of surgery. Infections in about 5 to 6% of patients, with pin track being the most common, but also osteomyelitis due to direct communication with the bone and the fracture sites. Understandably, you can have tendon injuries through inadvertent pinning through the tendon, or attritional ruptures with tendon buried under the skin, nerve injuries, malunion, and non-union due to too much fracture motion, need to go to the OR for removal, pin migration, and importantly, and that's why I have it in bold, delayed rehab, because when you pin these fractures, patients typically need to be immobilized for at least 4 weeks to allow for the fractures to heal before they can start range of motion. Open reduction and plating, the other common technique, allows for rigid fixation and early range of motion. However, studies have shown up to a 36% complication rate in these patients, stiffness, contracture, and extensor lag being the most common, likely due to the extensive soft tissue disruption that's needed in order to place these plates dorsally on the metacarpals. You can have malunion and non-union in 15% of patients, infection and tendon ruptures, revision surgery up to 32% of cases. So these metacarpal nails, do they provide a hybrid solution, a solution with minimal soft tissue dissection, rigid stability, and early range of motion? Well, we'll see. Very briefly, the history of these intramedullary fixation or intramedullary fixation techniques is kind of sporadic throughout literature, but in 1971, Milford suggested using medullary pegs of bone to treat malunions of the metacarpals. In 1973, Iselin and Thevenin suggested flexible screws introduced from the condyle into the canal of a metacarpal. And in 1978 and 1980, we see a mention of screw fixation by Tamai and Arigari, and this is a little depiction of the device they used. And it was actually used for replantation, where they would introduce this screw into an amputated digit, the proximal portion that was still attached, and then screw the amputated digit on top of the screw, and then perform their replantation over that. In 1981, we see one of the first series of intramedullary fixation published by Grunberg. They suggested using a cut Steinman pin or smooth Steinman pin through the fracture site of a metacarpal and use that to stabilize the bone. They touted very good results with only 2 complications, pin migration and 1 non-union. And then they suggested that one of the major benefits was being able to start motion as early as 10 days after the operation. And now in 2010, we see the first iteration of this common technique that is being used today with cannulated screw fixation, cannulated intramedullary screw fixation of these metacarpal fractures. It was published by Bolton, and it was a case report of intramedullary headless cannulated screw being used to fix a subcapital metacarpal fracture of the 5th metacarpal. They used a 3.0 millimeter cannulated headless compression screw. They initiated range of motion on postoperative day 5. They had no mobilization thereafter. Functional range of motion was achieved at 6 weeks, and union was achieved without any complications. The brief technique they used, and this is commonly what is used, though there have been different developments over the years, is an entry point over the metacarpal head with either a mini open or a percutaneous incision, which is inserted over the dorsal 1/3 of the metacarpal head. A guide pin is passed through a reduced fracture. A drill bit, a cannulated drill bit, is passed over this K-wire. And then on hand, a headless compression screw is placed for your intramedullary fixation. So let's start looking at the outcomes. Biomechanically, there have been many studies over the years with differing results. This is one I found in 2021 that was published where they compared plate and screw, lag screw techniques, and intramedullary screw techniques, fixing metacarpals with long oblique and transverse fractures. 3-point bend testing was used to test the stiffness of these constructs, and IM screws were found to have higher stiffness and peak load failure compared to the other fixation types. And they suggested that this may be the preferred fixation for return to work in sport. When we look at clinical outcomes, the first series that was published was 39 patients in 2014 and Journal of Hand Surgery. They fixed neck and shaft fractures of the metacarpal. All patients had range of motion, full range of motion by 3 months. They had union by 6 weeks in 100% of cases, and the average grip strength was actually stronger than the contralateral side at 105%. Probably the largest series that has been published with 91 consecutive patients by Eisenberg in 2020, 91 patients. They had three months to 1 year follow-up. 100% achieved full composite flexion. 100% were using their hand without restrictions at 6 weeks. And radiographic union was achieved by all patients. And at 76% of these patients had union by the end of week 6 following their surgery. They actually had 2 successful treatments of non-unions and malunions as well, suggesting a broadened scope of indication for the use of these intramedullary nails. And then finally, 2 systematic reviews recently published. One in 2018 had 169 metacarpal fractures. They had a great MP flexion at 86 degrees at final follow-up, 100% union rate again, grip strength at 96% of the contralateral side, and no serious complications and 9 minor complications. Study published in 2021 with 693 metacarpal fractures at an average time to union of 5.7 weeks, a complication rate of only 3.2%, 2% of this being limited joint motion, less than 1% being loss of reduction, infection, and screw protrusion, so a very low rate of major complications. And great range of motion and grip strength at 97.5% of the contralateral side. And the average duration of sick leave was only 7.3 weeks from work. But understandably, with any new fixation type, there's definitely concerns about, and there should be, because nothing is perfect in orthopedics or any type of surgery for that matter. Probably the most cited concern with intramedullary fixation and metacarpal fractures is this necessitation for penetrating the articular surface, which led to this study being published by Urgelsman, the same group that performed that initial study and case study in 2010. They did a quantitative 3-dimensional CT analysis of intramedullary headless screw fixation, and they found that at maximum there's only 12% overlap with the entry of the intramedullary screw in the base proximal articular surface of the phalanx. This is actually a cadaveric example of this, showing that in 20 degrees of relative hyperextension of the metacarpal phalangeal joint is when you start to see overlap of that entry site. And that's not really a physiologic position of the finger unless you're someone like a gymnast who relies on that motion at the joint. People said that there are limited indications for the use of metacarpal nails, and for the most part, this is true. Most are suited for transverse length stable metacarpal neck and shaft fractures. It's not very beneficial for complex interarticular fractures. And shortening with comminuted and long oblique fractures has been described, particularly with headless compression screws. But the indications are broadening. There have been non-compressive screw designs, such as seen in this image here, where we see this long oblique fracture being successfully treated by an intramedullary screw because it's not compressing through the fracture site. And other examples show this short oblique fracture, a distal fracture, transverse fracture, multiple fractures of separate sizes and locations. Successful treatment of a non-union on the left of your screen there. And very cool case that I was actually a part of as an intern, where a successful transposition after a bad trauma, the metacarpal that was transposed was fixed with a cerclage wire and reinforced with the metacarpal screw. Another concern is canal and screw mismatch. There are a wide variability in metacarpal dimensions between humans. Limited availability of IM screws because it is a relatively new technique. And if you use the wrong size screw or a vendor doesn't have the appropriate size available, you can have poor purchase or difficulty passing a screw in someone's metacarpal, which can be an issue. There's actually been recent studies published in 2020 and 2021 suggesting radiographic parameters in order to select the appropriate screw size and the appropriate vendor when you're electing to use this fixation technique. So it could feasibly be a limiting factor or difficult to use in certain medical communities. And then finally, cost. People cite that there's a higher initial implant cost compared to things like simple K-wire fixation, which is certainly true. But there are some studies, and this one was published in the UK pretty recently, so it might not be as applicable to our healthcare system. But they found that follow-up costs when comparing smooth K-wire fixation and intramedullary screw fixation in metacarpal and phalangeal fractures, that K-wire fixation was actually more expensive due to complications post-operatively, and particularly the need to remove buried K-wires, which necessitates a return trip to either a minor procedure room or to the OR. So going back to our cases, what now? We see this 22-year-old left-hand dominant male. He's healthy and struck this wall. Well, as you guessed, we put an intramedullary nail in it. 3 weeks out, he was ranging without restriction, had near full extension, and is starting to use his hand for ADLs and light painting activities. He's very happy with his outcome. This 30-year-old female involved in an MBC rollover with multiple extremity fractures, intramedullary nails. She was using her hands for very light ADLs at 1.5 weeks, full weight bearing on the hand by 5 weeks post-injury, and made mobility substantially easier for her. And finally, this was actually a case, this malunion case was taken from a case study I found online where they performed a mini open closing wedge osteotomy and fixed it with an intramedullary screw, successfully returning the patient's hand function without discomfort. And this was just an example of the broadening indications of intramedullary screws, and something we even see at our institution very frequently with acute corrections over nails and long bone fractures, such as tibial and femoral deformities. So in summary, there's currently no gold standard for the operative management of metacarpal shaft fractures. Metacarpal nailing with cannulated screws is a promising new technique. It shares many of the benefits of nailing long bones. And feasibly, it's a relatively simple technique in straightforward cases that can be used by people in the community if they have the resources available. The benefit of early unrecognized range of motion unrestricted range of motion cannot be understated in the polytraumatized patient, a laborer, or athletes. And expanding applications of metacarpal nails to issues like deformity correction, non-union correction provides exciting new options for hand surgeons. My resources, I'd like to thank Dr. Gaston, Dr. Gant, Dr. Chatterton, and Dr. Loeffler for their assistance. That's it.
Nice job, Alex. Well done. It looked like there were a lot of different implants used. Is there a preferred screw set or implant for this, or does it depend on the indication?
I imagine it depends on the indication. I know here, and Dr. Gaston probably would be able to touch on this better than I could, and we use Exosmed and innate nails pretty regularly here at this institution, but I don't know if someone else in the hand department can touch on that more.
One of the challenges is there's not people that take one specific for metacarpal fractures, but with that being first, otherwise you're using other things like compression screws. Biggest challenge we run into is yellow on all that, while a lot of this all kind of attack or down. Other things I'll touch on one is balance size. First thing to do is lay the proposed screw in that grade. That's been a real game changer for me. Now I'm not supposed to talk a lot of these on
That's a common indication, actually. You know, when I was at Fort Bragg, when the Marines would come over for a concert, there'd be 20 of these waiting for you the next morning. And they would always want to know when they could get back. So can you say one more time? Because I don't think that was picked up on the screen. How long to get back?
I was saying the fastest I said from back about 10 days.
10 days.
Soldiers, but for athletes, there's a lot of other factors. They play protected and everything else. They can play protected. They can go back. They're unprotected position. Depends on where you are in the season and some other factors that go into early though. I prefer not to have
The question was, and I don't know if it picked up, was how quickly can high-level athletes or soldiers return to activity after these? And For soldiers, Dr. Gesson said the quickest he sent somebody back was 10 days afterwards. He said for athletes, if they can play protected, he can start them with protection with padding over their operated hand within days, typically after sutures come out. But then after that, if they have to play unprotected, then it's a little bit longer, but still pretty rapid return to high intensity activity.
All right. Thanks, and we'll see you all next week, hopefully in person. We'll let you know. Good job.